Okay, hello. I'm speaking to everyone from Cat Island in the Low Country. Before I get started, I'd like to thank Dr. Walker for the opportunity to participate in this educational series. I would also like to thank the NCBH team who's making it all happen. The title of this talk is The Prevalence of Peripheral Artery Disease and Drivers of Associated Costs. Disclosures, none that are relevant to this discussion. In 2020, if we look at the US prevalence of selected chronic diseases, we see that at 21 million, PAD exceeds coronary disease, all cancers, exceeds everything but diabetes at 34 million. Yet, PAD continues to be underestimated. The most commonly quoted number, 8 to 12 million, the Criqui Partners number, was a good estimate for the US population circa 1995. However, since then, the population has aged and become considerably more diabetic, two key risk factors for PAD. If you revise the Criqui partner numbers for the 2020 population using their percent prevalence by age group, the number is 12 to 19. The range is 12 to 19. Likewise, if you make the calculation based on Nealer and Group's percent prevalence for those age 40 and over, the number is 19. Both of those high-end numbers are in line with the diabetes method estimate of 21 million. The annual economic burden of PAD is considerable, between 274 and 518 billion. The lower figure represents the US REACH population, both inpatient and outpatient costs. The higher figure is the Margolis managed care study costs. Both of these looked at inpatient and outpatient costs. The difference is that the REACH registry looked at cardiovascular costs only, whereas the managed care study looked at all cause costs. Hospital costs represent the majority of PAD costs, or about 70 to almost 90% of the total, or 184 billion in REACH, 456 billion in the managed care study. Non-PAD costs are significant. If you look at cardiovascular hospitalizations, then cardiovascular represents 43%. PAD is only 57%. If you look at all-cause hospitalizations, however, non-PAD costs are 90%. Who pays the bill? Medicare and Medicaid pay 80% of the bill. In other words, our tax dollars. Looking at PAD patients in Medicare, between 10 and 21% of Medicare patients are treated for PAD at a per patient cost of between $25,000 and over $80,000. Now that's a huge range. It reflects the definition of PAD and the types of treatments included. In particular, long-term care is included in that higher number. Most importantly, above-the-knee amputation is the third most commonly performed procedure in Medicare patients. If you look at that $80,000 plus spent on the average PAD patient in Medicare, that's over 6 times higher than the $12,000 plus spent on the average beneficiary. The majority of PAD patients have polyvascular disease. Only about 30% have PAD by itself. The rest have some combination of PAD with coronary and cerebrovascular disease. The biggest single category is PAD plus CAD, which is almost 50%. Polyvascular disease costs more. PAD by itself costs about $12,900 annually, a little bit more for PAD plus CVD, but when a patient has PAD, cerebrovascular disease, and coronary disease, the costs are almost $23,000. You look at the annual economic burden of PAD compared to other diseases at 274 to 518 billion. PAD exceeds diabetes, 237 billion, and all cancers put together cost about $88 billion. So this is a very expensive disease. Turning to CLI, the prevalence in 2020 is estimated at 2.1 to 3.8 million. Now that's prevalence. Only 700 to 800,000 are actually diagnosed and treated either with revascularization or amputation. If we look at prevalence projected going out from 2020 at 3.8 million, by 2030, it's estimated to increase to 4.7 million. And that's based on the aging population only, and holding the prevalence of diabetes constant at the current levels. If diabetes continues to increase as it has in the last 20 years, then that 4.7 million will be a conservative number. Looking at interventional therapy costs, it's actually only in the last few years we've started to get cost data on CLI. The top series of numbers look at inpatient or hospital costs of endovascular bypass, major amputation, different combinations of those. And you can see per patient cost range between about $25,000 and over $32,000. We also have inpatient and outpatient cost data from Medicare patients. And in this, it's broken down by bypass is $49,000 plus, endovascular is a little bit more. Major amputation cost almost $56,000 in Medicare. The annual economic burden, we have several estimates for that. The cost of inpatient CLI interventional treatments exceeds $4 billion. The cost of incident CLI in Medicare has been estimated at $12 billion, and we have estimated all-cause costs of prevalent CLI at between $220 and $300 billion. So why is CLI so costly? Well, we saw that interventional therapy is very expensive, and amputation is the most costly of those therapies. There are numerous other factors that add to the economic burden, and the key point is that most are modifiable or preventable. Amputation costs more than revascularization. Initial procedure costs are very similar for amputation, endovascular, and bypass. However, if you look at total costs, which include initial procedure costs plus morbidity, mortality, and revision procedures, the cost of amputation is over $40,000 versus $26,000, $27,000 for endovascular and bypass. We have 65 to 80,000 major amputations performed annually. Estimated direct medical costs at $12 billion, and a total cost of $23 billion, adding in the lifetime costs. We'll come back to some cost data in a minute. Amputation and mortality increase with disease severity within CLI. We look at 4-year amputation rates in Rutherford category 4, 6% amputated in 4 years. But in Rutherford category 6, 30% underwent amputation. Similar trends with 4-year mortality rates, 41% dead in Rutherford category 4 at 4 years, but almost 70% dead in Rutherford category 6. So again, we could ask the question, so why is CLI so costly? Amputation is only one of many factors. It's an important factor, but it's only one. Numerous other factors add to the economic burden, and again, I emphasize most are modifiable or preventable, and we'll go through some of these. Treatment costs increase with disease severity. Inpatient treatment costs for intermittent claudication over $20,000 versus $32,000 or so for CLI. Within CLI, treatment costs increase with disease severity. So Rutherford category 4 patient costs about $24,000 to treat, more for Rutherford 5. Rutherford 6 patient costs almost $40,000. So all of this suggests earlier diagnosis and treatment could reduce costs. CLI patients are getting sicker, and there's very high non-CLI admissions, and this adds to the cost burden. We've seen an increasing prevalence of hypertension, obesity, chronic kidney disease, and diabetes, plus patients presenting with prior amputation. Significantly, only half, a little bit more than half of these admissions are due to the primary CLI. The rest are due to diabetes, septicemia, post-procedure complications, cardiovascular, etc. Diabetes is present in the majority of CLI patients. We estimate 60% of the CLI population has diabetes. That compares to 14% of the US population. And the presence of diabetes has a profound impact on CLI. Diabetics have more severe ischemia. They're more likely to present with ulcers and gangrene. CLI develops suddenly in diabetics. Diabetics have more amputations and a higher risk 28 times the risk of amputation increases with the severity of diabetes measured by HbA1c, and diabetes does increase CLI costs. Most CLI patients have polyvascular disease, and this also drives up costs. 60 to 80% have coronary or cerebrovascular disease. And the cardiovascular, hospitalizations, revascularizations, and deaths add to total costs. MACE, major adverse cardiac events, increase with the number of vascular beds involved, and we have conservatively estimated that MACE adds $17 billion to CLI costs. Risk factors undertreated in CLI patients, amazingly even compared with IC patients. Cardiovascular risk factor modification therapies are underutilized. Statins, antiplatelets, antihypertensives are all underprescribed. Glucose is inadequately controlled in 40%. Smoking persists in 27% to over half of these patients. And this suboptimal medical management increases the risk of amputation and/or death by 8 times. The result, major adverse cardiac and leg events, male, and increased cost. There's a high rate of readmissions. This also drives up costs. CLI readmission rates at 30 days are 20 to 27%. At 6 months, almost 60% are readmitted. And the 30 days compares to 15% for MI and 12% for ischemic stroke. The majority of these readmissions are unplanned. Importantly, less than a third of the readmissions are due to primary CLI-related causes. The rest are due to various non-CLI reasons: infections, procedure complications, cardiovascular events, and diabetes-related non-vascular problems. And unplanned readmissions increase mortality, male, and costs. One study estimated they add $624 million to the cost burden of PAD and CLI. So looking at CLI patients in Medicare in 2011, 2/3 were treated with a major procedure, bypass 20%, endovascular 40%, and major amputation in 6%. Amazingly, over half of the CLI patients who underwent major amputation had no prior revascularization. At 1 year, 29% were dead or had undergone major amputation, and median survival was abysmal, 3.5 years versus 13.4 years for age and sex-matched controls. So conclusions. PAD is highly prevalent and commonly underestimated. The macroeconomic cost is high, between 274 and 518 billion. Hospital costs account for the majority of PAD costs. Hospital costs are significantly increased by cardiovascular and non-PAD events. The 2020 economic burden of PAD exceeds that of diabetes, coronary disease, and all cancers combined. Mortality and amputation increase with disease severity. PAD costs increase with disease severity, suggesting that earlier diagnosis and treatment is likely to reduce the costs. CLI only costs 4 to 12 billion, that's incident disease, but all-cause costs 220 to 300 billion, that's prevalent disease. CLI costs are increased by treatment with amputation rather than revascularization. Treatment at more severe disease stages, diabetes, and cardiovascular events, undertreatment of risk factors, and unplanned readmissions increases the cost. Optimal medical management is underutilized in CLI, and it increases the risk of amputation and/or death by 8 times. Major amputations cost 23 billion, MACE cost 17 billion. The factors driving up CLI economic burden are modifiable or preventable, and we need more research on PAD and CLI costs and consequences. Thank you.